have a resection maybe for rectal cancer.
Okay. Okay. You do. There are. I misunderstood. Thanks for that. Yes. Sometimes a surgeon will remove a cancer of the rectum that doesn't involve the anal canal, so we don't have to remove the anal canal at all. And then our choice is to connect the remaining colon to the anal canal, which doesn't produce the best results. And what we do is we make a colonic pouch and connect it to the anal canal. So that's kind of a variation on a theme. And in that circumstance, the patient ends up with, it's not a J pouch because it's not made of the small intestine, it's a colonic pouch that's connected to the anal canal, so they evacuate the normal way. Any other questions? Yes?
I got to an argument about age. Well, no, bring it up because, you know, the lady was 78, was starting to have some arthritis in the hands. Do you see any contraindications besides the disease that you consider before you offer a pouch?
In terms of age?
Well, you know, what are the factors that you would consider like really discussing or discouraging as far as...
Okay. Well, you have to be able to manipulate the catheter. So a person who's had a stroke, has use of only one hand, could still manage a common pouch, but it would be difficult. Between putting it in and draining it and not making a mess when you pull it out. So that could be an issue. I mean, I've operated on patients with all kinds of disabilities or infirmities. I have operated on patients who've had strokes with not paralysis, but some minor limitations were able to manage fine. You know, you give a patient a catheter and say, see if you can do this with your hands. I had a patient who was very sick with colitis, and by the time they did the colectomy, he had developed blood clotting and all his fingertips had to be amputated. But he still had fingers. Did a continent pouch and he's been fine for years.
So you got to check the fine motor with the
Yes, I mean, you have to be able to do normal activities. And it's only an issue with people who have some other underlying neurologic disorder or some other incapacity. I mean, if you had an amputation of one arm, you could still manage. I mean, you could change an appliance if you have a conventional ileostomy. It would be a little tricky, but I'm sure you could do it. Same with a continent ileostomy.
Are there troubles with caregivers doing the catheterization?
No. No. If a patient becomes elderly and unable to catheterize, a caregiver can do it. Absolutely.
So it's not a sensation kind of thing. It's just mechanical.
Well, it's a sensation of, it's kind of similar to the bladder. You know, you get it, you know when you start to feel like maybe I need to find a bathroom and urinate, and then you can wait a while longer. You can wait a while after that too, but sooner or later you have to. With the continent diversion, continent ileostomy, you can wait a lot longer than a full bladder, but you will get uncomfortable as you continue to wait. Yes?
You know, I have heard that sometimes, like in convalescent homes, because it requires a little bit more time on their part, it's easier for them to deal with an ileostomy than it is a continent ileostomy. And I think that's a real shame.
Well, you know, it's worse than that sometimes. And there are many wonderful, of course, convalescent facilities, skilled nursing facilities. But sometimes it seems easier that if a patient has a bowel movement every 3 days rather than every day, you only need to clean them up every third day, not every day. So maybe there's an inclination to let people get constipated. That's the same kind of attitude you're describing. And most places will not be like that. So whether it's changing an external appliance, an external pouch for work ileostomy, or catheterizing several times a day, any caregiver can do that. It doesn't take very long. The patient doesn't have to get out of bed. They can be lying in bed, you put the tube in with a basin next to you, it drains into the basin. You're done in 30 seconds, 60 seconds, you take the tube out. Go on to your next patient. And family members can learn to catheterize you. If you get sick and you're not feeling well, you're recovering from some surgery.
Which family members?
A cooperative one. Yes.
Just to expand on that, after having the operation, you have to educate when you go back to your hometown, your own doctor, and in a lot of cases, your own hospital if you're admitted for something else. I've had that occasion because, you know, the numbers are not like ileostomies and colostomies in the world. We're a low number. So you have to go back and educate.
And I also recommend to patients that they have some kind of medical alert. If you don't want to wear a medallion or bracelet, just have something on a card attached to your driver's license. Because if you're in an accident and you're unconscious, the police and everybody are going to look for your ID. And they're going to find this card that says, I tell people to say, continent ileostomy intubation required. Now, most doctors and nurses will not know what continent ileostomy means, but every doctor and nurse will know ileostomy, look for a stoma. And they won't know what a continent ileostomy is all about, but if you write intubation required, they'll know put a tube in.
Yep.
Don't just put an appliance on and expect to see my bowel empty its contents, because it won't. So it's important to have that kind of card, and it's important to, you know, be proactive when you meet with doctors that may not be familiar with it. Yes?
I just want to know if you've seen a lot of patients with myelofibrosis.
Yes. There are many people with familial polyposis, and they are candidates for all the various options.
I have a J5 with myelofibrosis.
Right. And that's, like I say, that is the most commonly done operation for people that need to have their whole colon removed, because you get to evacuate the normal way, and hopefully this will last in your lifetime. Is what.
I've had it 10 years so far. So
Great.
thank you.
Excellent. Any other questions? Yes.
I was just wondering about the intubation tubes. You require a prescription, you get them from a DME, and they are reimbursed by
Okay.
Medicare.
The ileostomy catheters are the same as Brook ileostomy appliances. You can get them from similar suppliers. Your doctor can write a prescription, continent ileostomy supplies, put the diagnosis, tell you that you've had a continent ileostomy, whatever the code is. And if your insurance company would reimburse for appliances for a colostomy or ileostomy, they'll cover the cost of the catheters. Catheters are very inexpensive. They range from, let's say, $10 to $50 per catheter. Some catheters are more, some are less. But they last months and months and months. After a while, they may get a little discolored, and after a while, they may stiffen. Their consistency changes, even though they're made out of silicone. So I don't recommend that patients keep a favorite catheter for years, because little cracks can develop in the silicone, and after some point, you don't realize it, and it may cause an irritation or tear and cause bleeding. But it's easy to get. Yes.
If in your hometown you don't have someone that does these kind of surgeries and you have to go out of town, is there a problem with follow-up, or if you have a problem?
No, my routine with patients is, and many patients come to see me in Los Angeles, they are coming from out of town or out of state or other countries sometimes. Once you leave the hospital, you will know how to catheterize, you will have done it yourself for a couple days, you will be able to take care of this the rest of your life. But then I have a strict follow-up schedule, at least for the first 6 months. The difference is, instead of seeing me a week or two after discharge, coming in through my front door of my office, you're calling me on the phone, and I'm there, you're on the office schedule, that's your appointment, I have your chart, I take notes with every telephone visit, and you know, there's kind of getting people through the growing phase, the growing pain stage as the pouch expands. If there's a problem related to the pouch, you have to go back to a pouch surgeon to have it taken care of. If there's an issue that doesn't require surgery, maybe you need to be scoped to see if the pouch is inflamed or not. Any local gastroenterologist can do that, and I often communicate with local doctors. I've had many patients, you know, you need a total hip replacement. I'm not going to be able to intubate myself for the first day. How do I manage it? Well, I talk to the patient, I talk to the surgeon. It's very easy. You could put a catheter in, a soft urinary type catheter, connect it to a drainage bag. It'll flow continuously, and once you're recovered from your surgery, you take that out, you start your own self-catheterizer. And then pouch surgeons are different than other surgeons. It's not that we're better than other surgeons, but we are different. Most surgeons want to do vertical care. You take out the appendix, you take out the gallstones, you take out the whatever, and you go to the next patient, and you don't hear from that patient anymore. With pouch patients, we're kind of committed and devoted to following them indefinitely, being available for questions or concerns, or like this, you've had your pouch for 12 years and now you need another surgery. How do you manage it? We're there for that. Many surgeons don't want to be doing that longitudinal care. They just want to go on to the next patient. but pouch surgeons aren't like that.
I know, my